Hello, welcome everybody to this edition of What's New in Addiction Medicine. Hopefully everyone can hear me. So today we have a great talk on alcohol use disorder and high-risk drinking, and Dr. David Reading will present for us, one of our addiction medicine fellows. David is a general internist and one of our addiction medicine fellows finishing his training at the end of this month. He completed medical school at the University of Calgary and his internal medicine residency at UBC at the Vancouver Island site. His interests are the intersection of chronic disease with substance use, reducing barriers to general internal medicine and substance use care, and medical education. So let's give a very warm round of virtual applause to David Reading. Thanks so much for being with us here today, and we're all really looking forward to this talk.
Thank you so much for the introduction, and I'm really grateful to be able to be here and to share some of my findings from doing a bit of a literature deep dive earlier this year. So I want to start off by respectfully acknowledging with gratitude that I live, work, and play on the traditional, ancestral, unceded, and continually occupied territory of the Lekwungen and Tenshathan-speaking Coast Salish people, locally including the Esquimalt, Songhees, and Wasanich nations. And as conflict of interest, I'll be making reference extensively to the 2019 BCCSU guidelines for alcohol use disorder and high-risk drinking, and they are my employer. I will be discussing the off-label use of medications in this presentation, and as much as possible, I'll avoid the use of trade names for medications. So using a newer network meta-analysis that was published last year as a sort of a point to return to over the course of the conversation, I'm going to talk about alcohol use disorder in the local landscape with a focus on Victoria data as well as BC data. Some of the established evidence and recommendations for treatment, that sort of surface level thing that I hope that can be provided to all of our patients at any door that they walk into. Some emerging areas of interest in pharmacotherapy and reflection on this meta-analysis, and then pragmatic considerations and a plea for your involvement in looking after our patients. My objectives are made available in the email ahead of time, but they're similar to the outline. Within the scope of what we're going to talk about today, I'm mostly talking about reduction in high-risk drinking and reduction in relapse. Not today am I going to get into alcohol withdrawal management or specific evidence for the management of alcohol use disorder in pregnancy or in youth, or while I'll speak to some of the psychosocial resources that are available locally, I'm not going to be evaluating those psychosocial resources. I'm certainly happy to talk about any of those things in questions, but I'm going to focus on pharmacotherapy for relapse prevention today. So I've made an application to the most local data that I can manage. I think everybody who's listening today is probably already convinced that alcohol use is an important contributor to poor public and individual health outcomes. I live and work in Songhees and Esquimalt territory, and so I've made an application to our island health data. This image is from CSER at UVic, the Center for Substance Use Research. They have a really fabulous tool that allows you to explore the population level rates of hospitalization, death, premature death, and substance use, stratified by health region, and I encourage anyone that's interested to tinker with it. When I pulled this graph, they only extended as recently as 2019, but they demonstrated this fairly sharp uptick in hospitalizations in which alcohol use was a factor. And while we don't yet have the numbers, this pattern doesn't seem to have changed, and data from the United States actually suggest that it continued to increase. Data specifically for the Greater Victoria area are similar, but with a bit more variation related to lower numbers, and the rates in the interior and in the north are higher, and rates in coastal and Fraser are a little bit lower. These Canadian Institute for Health Information data are a little bit more contemporary, extending as recently as last year, and they show something similar. In island health, we have almost twice the national average hospitalizations, this time entirely caused by alcohol in our hospitals. And again, you know, in interior and northern health, it's a little bit higher. In Vancouver and coastal, it's a little bit lower. So recognizing that alcohol use is a common and increasing factor in hospitalization, and the utility of pharmacotherapy to support patients with substance use disorders, uptake in the use of these medications is relatively poor. Recent data and BC data are lacking, but as an example, in a retrospective cohort in Ontario about a decade ago, only 0.4% of patients hospitalized with a diagnosis of alcohol use disorder were dispensed acamprosate or naltrexone in the year following their hospitalization. In the States, they do these wide national random surveys where they assay patients for the diagnostic criteria for alcohol use disorder, whether or not they have that diagnosis historically. And they find that about 30% of adults will meet criteria for an alcohol use disorder in their lifetimes, and only about 1 in 5 patients with a lifetime diagnosis of alcohol use disorder ever receive treatment. So hospitalization related to alcohol use is common, alcohol use disorder is common, and alcohol use disorder is undertreated. We know this, we see these patients every day. The recommendation for non-specialists is generally to engage in something called SBIRT, or screening, brief intervention, and referral to treatment. Screening involves asking all your patients if they ever consume alcohol, getting basic details around their use, and potentially administrating a validated tool like the CAGE, CRAFT, or Audit C, or honestly the single question screener, ask them if they drink. Brief intervention means having a brief, non-judgmental, and sincerely curious conversation with the patient about their goals and their use. And referral to treatment is super patient and site specific. It might involve a direct referral to a treatment resource, the involvement of the addiction medicine consult service for admitted patients, referral to the rapid access addiction clinic, consultation with the Raceline physician, or referral directly to psychosocial resources in the community. If you're comfortable, the 11 DSM-5 criteria for alcohol use disorder are relatively easy to evaluate with the benefit of a pragmatic conversation with the patient about their use. And they're easiest to summarize, recognizing this doesn't map directly to the criteria as the 5 C's and the 2 physiologic symptoms. Physiologic symptoms being withdrawal intolerance, and the 5 C's being markers of psychosocial dysfunction, loss of control, cravings, health and relationship consequences, the compulsion to drink, being able to cut back, and other factors. 2 to 3 represent a mild use disorder, 4 to 5 a moderate use disorder, and 6 or great a severe use disorder. So your patient has an alcohol use disorder, newly diagnosed or well established. This is a slide ripped directly from the BC CSU AUD guidelines for your reference, and we're going to walk through it step by step in a lot of detail. But the bottom line is that naltrexone and acamprosate are both extraordinarily well established and safe treatments with moderate efficacy in the reduction of alcohol use related harms. And for reasons that we'll explore in the coming slides, anyone with a moderate or severe alcohol use disorder should be offered these therapies as first line. So naltrexone. Naltrexone is a mu opioid receptor antagonist with good central nervous system penetration. Theoretically, this diminishes the rewarding or euphoric effect of alcohol consumption, making it useful for patients that don't have a goal of abstinence, though the evidence for this is much more limited than the evidence for abstinence. This mechanism of action makes it obvious why it's contraindicated in patients that will continue to take opioids after naltrexone initiation, though it's commonly used in much of the world for support of abstinence and opioid use, and why it might present issues in the perioperative setting. There are numerous frankly upsetting anecdotes about patients becoming injured or undergoing surgery with inadequate analgesia as a result of being prescribed naltrexone, and this is an important counseling point that should be discussed with every patient prior to initiation. Theoretically, it's also contraindicated in severe liver disease, but I'll spend more time on this specific topic in the coming slides. Probably the most widely cited review of the evidence for naltrexone comes from this systematic review and meta-analysis published in JAMA by Jonas et al. In 2014. It was a systematic review and meta-analysis of 151 articles reporting on 123 studies and including 22,000 patients assessed for at least 12 weeks in outpatient settings. They evaluated adults with alcohol use disorder, and studies had to evaluate an FDA-approved medication or any of 23 off-label medications. It was mostly acamprosate, naltrexone, or both. Most studies, as is common, were completed on patients after withdrawal management or a period of at least 3 days of sobriety, and typically included psychosocial co-intervention. The key finding was that oral naltrexone, the key finding for naltrexone anyway, was that oral naltrexone had a number needed to treat of 20 for abstinence and a number needed to treat of 12 for preventing return to heavy drinking. That is to say, for every 20 patients that took the naltrexone, 1 did not return to drinking by the end of the study period, and 12 did not return to heavy drinking. And heavy drinking is defined differently in different trials, but it's usually somewhere in the realm of 4 to 6 drinks in a day. There's really no way to unpack a forest plot, unfortunately, but in this forest plot for the effectiveness in preventing return to any drinking, the cumulative effect is significant for naltrexone at the 50 milligram dose, but it's relatively small. As an example of benefit, even in patients that don't reach abstinence, A few years before the systematic review was published in 2010, a Cochrane review of the use of naltrexone and nalmefene, another opioid antagonist that didn't really bear out and is now being evaluated for treating opioid overdose, found that naltrexone was effective in reducing the risk of heavy drinking, reducing heavy drinking days, reducing the percentage of heavy drinking days, reducing the consumed amount of alcohol, and reducing gamma-glutamyl transferase elevations. The MD on this slide is mean differences between the study group and the control group. This older study didn't demonstrate benefit for return to any drinking. Side effects were as anticipated: rare nausea, rare sedation on the order of about 10% of patients each. And anecdotally, these side effects can be mitigated by up-titrating from a lower dose of naltrexone over a few days. Most recently, a network meta-analysis of the previous, as well as a few more contemporary trials, was published just last February by a group of researchers, including a few familiar local names. Dr. Baji will actually be presenting on cannabis use disorder later this week, I believe. We're going to come back to this slide a few times over the course of the presentation. So we're going to unpack this overwhelming amount of information. But I just want to highlight that while the overall effect size is moderate, there is minimal signal for dropout, very minimal dropout from adverse events, and a reliable improvement in abstinence and heavy drinking. These numbers are reported as rate ratios, which is a somewhat counterintuitive way to think about abstinence, but that's the way that it's reported. It's the ratio of incidence rate for a particular outcome over time. And then naltrexone is highlighted in each of these forest plots, with dropouts in the top left, adverse events in the top right, abstinence in the bottom left, and heavy drinking in the bottom right. So liver disease. Hepatotoxicity, or at minimum liver enzyme elevation, has been a subject of great concern in the potential application of naltrexone use in patients with or at risk of liver disease. There's no longer a black box warning for hepatotoxicity, and there have been no proven cases of clinically significant naltrexone-associated liver injury. Elevated liver enzymes have, however, been documented. As food for thought, this retrospective cohort was recently published in JAMA, evaluating the impact of pharmacologic treatment for alcohol use disorder on the development and decompensation of liver disease. They have a database of 127,000 patients that they examined retrospectively and found that receiving any pharmacotherapy for alcohol use disorder was associated with less development of liver disease and less decompensation in patients that eventually become cirrhotic. Even in patients that start with a diagnosis of cirrhosis or that developed cirrhosis during the period surveyed, treatment, including treatment just with naltrexone when you look at subgroups, significantly delayed the time to next decompensation. The cohort of patients that begins with cirrhosis was too small to demonstrate an association specifically for naltrexone, but the cohort that included those that developed cirrhosis was. Other findings included that patients on acamprosate were more likely to have alcoholic liver disease, which seems obvious. These are retrospective data. We're evaluating clinician behavior as much as we're evaluating what happens to our patients, and we tend to switch patients to acamprosate when they develop liver disease. So while acknowledging this is a retrospective trial, I do think this challenges the dogma that naltrexone is inappropriate for patients with liver disease. And the conversation about the risk and benefit of the use of a once daily drug is worth having with your patient with appropriate cautiousness. So that's naltrexone. Acamprosate. The mechanism of action for acamprosate is complex and it's indirect and it's not fully understood, but it's thought to balance or restore imbalances in neural activity dysregulated by chronic alcohol consumption. It was FDA approved in 2004, but is used in Europe well before that, and it's been extensively evaluated since. The only real contraindication, aside from a specific allergy, is renal impairment. It has to be dose adjusted in chronic kidney disease, and it probably shouldn't be used with a GFR of less than 30. Practically, the reason it's not used quite as often as naltrexone is that the typical dose is 666 milligrams by mouth 3 times daily, which is a total of 6 tablets, which is a lot. Probably the most impactful meta-analysis evaluating acamprosate comprehensively is a Cochrane review published in 2010. In evaluating all double-blinded RCTs, which included drinking-related outcomes and compared acamprosate against placebo or active controls, they included 24 randomized controlled trials and about 7,000 participants. And they demonstrated a significant reduction in the risk of any drinking and duration of abstinence. And interestingly, this effect persisted for 3 to 12 months after treatment discontinuation, an effect that has not been demonstrated with other agents and was theorized to be related to its long half-life. It's not been demonstrated to reduce the frequency or time to heavy drinking historically, which is why naltrexone has been the first line recommendation for patients hoping to cut down on their alcohol use. To return to that same Jonas meta-analysis that I referenced for the number needed to treat for naltrexone, acamprosate had a number needed to treat of 12 for abstinence, relative to naltrexone's 20. There was no statistically significant effect for return to heavy drinking, and as mentioned, because of this result, and similar results demonstrated in subsequent systematic reviews, acamprosate is typically not recommended for patients whose goal with respect to their alcohol use is not abstinence. That said, those data are now more than a decade old. To return to the 2022 meta-analysis, where now acamprosate is highlighted, with the benefit of another decade of data, though few new trials, and the application of network meta-analysis, which is a novel, relatively novel technique for making comparisons between drugs that wouldn't necessarily have been compared under other circumstances, and I can talk about that in depth near the end if people have questions about the method. Acamprosate likewise had a small but reliably demonstrated positive effect on abstinence, and actually also on heavy drinking, while having few dropouts related to adverse events. It's worth keeping in mind that most of these trials enrolled patients after discontinuing alcohol, but this may challenge that typically held belief that acamprosate is inappropriate for patients without a goal of long-term abstinence. For many people, the challenge with acamprosate, which has a very strong evidence base, is the TID dosing and the fact that it's 6 pills. What's interesting is that early pharmacokinetics trials in healthy volunteers, including this one from 1998 in which patients received acamprosate as either BID or TID, are reported as bioequivalent. There's still a reason to prescribe the medication as TID. It's the way it was done in all the trials for reasons I don't totally understand. It has a very long half-life. But I do think that these data raise the question as to whether it's acceptable to prescribe this medication as BID or even daily for appropriate patients. So in summary, naltrexone and acamprosate are the recommended first-line therapies for most patients. Naltrexone is well established. It has the largest evidence base, with good evidence for both abstinence and reduction in heavy drinking. Contraindications include ongoing opioid use and theoretically liver disease. Side effects are uncommon and anecdotally can be mitigated by starting at a half dose for 1 to 5 days before up titrating. Acamprosate is likewise well established in the literature, historically for abstinence only, but with some emerging evidence that there might be a reduction in heavy drinking. It has to be dose reduced with a GFR of less than 50, and it's contraindicated with a GFR of less than 30. And diarrhea is the most common side effect, but this is typically transient. And both should be covered for your patients because of changes relatively recently, and we'll come back to that near the end. So those are the first-line therapies. Included here are alternative therapies with at least some previously established evidence for the treatment of alcohol use disorder, as well as some select novel therapies under investigation since the publication of the most recent BC-CSU guideline. The bolded ones are the ones that are commonly used in BC. And today, for time, I'm just gonna speak about the ones that we see most often, but I'm happy to take questions on any of these or any of the many others that have been trialed, because we've known about this condition for more than 100 years, and we've tried a tremendous number of things. With the recognition that medication compliance in the real world and in substance use trials in particular is suboptimal, as well as recognizing a lack of clarity about the duration for which patients should be treated for an alcohol use disorder with pharmacotherapy, a pattern of naltrexone use has emerged in which patients are instructed to take it as needed prior to engaging in activities that are judged high risk for heavy drinking. This has been monetized in some circles as the Sinclair method, and you might hear patients using that terminology when they describe their naltrexone use. This is supported by a series of relatively small trials summarized in a review by Mark Nishu and Albert Arias in 2013. The first trial was by Kranzler et al. In 1997, which was this single-site uncontrolled open-label study of 21 patients, which raised the question of whether or not this might be helpful for some patients, but didn't really answer that question. So it's followed up by a trial by the same group in 2003, and just prior to that, a group by Dr. Heinala et al. In 2001, which was double-blinded RCT with 4 arms. Patients were randomized to either naltrexone or placebo, and either cognitive coping or supportive therapy. There was in 2 phases. They started off with daily therapies, and then they moved on to targeted naltrexone after a period of time. Giving naltrexone and coping separated from placebo and coping, but interestingly, naltrexone and supportive treatment didn't differ significantly from placebo and supportive treatment. I don't really know what that means in this context. Dr. Kranzler et al. Followed this up with this trial in 2013, single-site, double-blind, placebo-controlled RCT, again with 4 arms, where patients received targeted naltrexone, targeted placebo, daily naltrexone, or daily placebo. There's this interesting design in that targeted therapy they dispensed one less pill per week over the course of the trial. And they saw a reduction in the probability of heavy drinking with both daily and targeted naltrexone. But targeted naltrexone fell off and was no longer useful when the patients got to less than 3 tabs available per week. A replication study was completed in 2009, another double-blind placebo-controlled RCT with the same 4 arms, but they didn't do that thing where they dropped the dose 1 per week. And in this one, they found that targeted naltrexone decreased the number of drinks per day in men, but interestingly not in women. And then another group did this long, Loxone et al. Did this long, greater than 1 year open label trial of continuous and then targeted therapy. And they found no significant differences between the groups in time to first heavy drinking day or the day to first relapse. They also included targeted acamprosate and disulfiram, which are interesting ideas that I don't see very often. And they had more abstinence in patients receiving disulfiram. But disulfiram patients are sort of a different group of patients, and we'll talk about that a little bit more. The bottom line from all of this is that this is a very small number of trials. There hasn't really been a consistently replicated benefit for this practice, and that for patients who are taking their naltrexone less often than most days, that benefit becomes even more debatable. I'm just going to speak briefly about intramuscular naltrexone, as it's not available in Canada by any means other than through the Special Access Program, which requires an application to the government on the patient's behalf, and then to have the patient to pay for it out of pocket. There are a small number of trials that have evaluated intramuscular naltrexone for alcohol use disorder. Its primary use case in the US is actually for opioid use disorder, but it's been promising with some of those more recent trials for alcohol use disorder. Historically, effects have been less impressive than daily oral naltrexone, but in the most recent meta-analyses, the magnitude of effect seems similar to daily oral naltrexone, albeit with a much lower level of confidence for efficacy given the quality and breadth of the data, and without clear systematic review level evidence for reduction in heavy drinking days. Gabapentin. Gabapentin is nominally an anticonvulsant used widely for many purposes, including partial seizure, neuropathic pain, alcohol withdrawal, and as in this case, alcohol use disorder. Despite its name and its structural similarity to GABA, gabapentin doesn't bind to the GABA A or GABA B receptors, and as far as we can tell, is essentially unrelated. Instead, it binds to a subunit of calcium channels throughout the body and modulates calcium channel activity. And if it has anything to do with GABA transmission, it's indirect. In my experience, after the first-line therapies, gabapentin is used most often in British Columbia for alcohol use disorder, and typically working up to the dose of 600 milligrams by mouth 3 times daily. But let's explore a little bit of the evidence basis for its use. The most current meta-analysis for the efficacy of gabapentin in alcohol use disorder at the time of the publication of the guidelines was published in Addiction in 2019, and it evaluated 7 RCTs, demonstrating that the only significant reduction in effect was a reduction in the percentage of heavy drinking days, with a 95% confidence interval between -1.22 and -0.06. But there was signal towards effect in abstinence, relapse prevention, drinks per day, and percent days abstinent. And the source, as best as I can tell, for the collective practice of giving 600 milligrams of gabapentin by mouth 3 times a day comes primarily from this paper, which is a 12-week double-blind, placebo-controlled, single-center randomized controlled trial of 150 men and women enrolled between 2004 and 2010. Patients all received counseling, as is common in these trials, and were randomized to either placebo, 900 milligrams of gabapentin daily in divided doses, or 1800 milligrams of gabapentin daily in divided doses. And saw this dose-responsive reduction in heavy drinking and promotion of abstinence, heavy drinking being on the left, abstinence being on the right. These are my titles, not in the original slide. So while dropout rates being relatively high as the norm in substance use literature, the dropout here was, however, more than expected at 43%, even just over the 12 weeks assayed. That said, there was no differential dropout between treatment groups. And I want to call attention to the fact that the p-value on these graphs is for linear dose effect. So I think the takeaway from these trials is that when patients are prescribed more gabapentin, they tend to have less heavy drinking days. But this doesn't necessarily inform us that 600 milligram 3 times a day dose is optimal, just that more probably reduces heavy drinking. I also think a lot about this trial performed in by Anton et al. In 2020. In this double-blind RCT, they randomized 96 patients to escalating doses of gabapentin, concentrated in dose at night versus placebo. And they stratified patients by high or low self-reported symptoms of alcohol withdrawal after 3 days abstinent. The number needed to treat for a reduction in heavy drinking was 5.4, which is significant relative to other trials, and with a number needed to treat of 6.2 for total abstinence at 16 weeks. This difference, however, was almost completely driven by the people with high self-reported alcohol withdrawal symptoms, with a number needed to treat of 3.1 for a reduction in heavy drinking days, and a number needed to treat of 2.7 for abstinence. There's no significant difference for either in patients with low self-reported symptoms. The provocative question that this asks is, are we mostly treating alcohol withdrawal in these patients, and is there a role for shorter-term gabapentin prescribing? The 2022 meta-analysis challenges this practice to some degree, failing to demonstrate a significant effect for the use of gabapentin in promoting abstinence or reducing heavy drinking. While the absolute value of the purported effect is comparatively large relative to better established therapies, the evidence basis is small and our confidence in that effect is low. It's also worth noting that some concerns are beginning to arise about use of gabapentin by means other than as prescribed. Qualitative studies have suggested that one of the more common use cases for gabapentin used by means other than as prescribed is for mitigating symptoms of withdrawal, but it's worth being aware of. And of course, while outside of the scope of the presentation today, gabapentin has utility in the management of symptoms associated with uncomplicated alcohol withdrawal. Disulfiram is an acetaldehyde dehydrogenase inhibitor. The typical metabolism process for alcohol involves breaking ethanol down into acetaldehyde and then subsequently into acetic acid or vinegar. The prevention of the last step of this process causes what's called the disulfiram alcohol reaction, which is unpleasant at best and can be life-threatening at worst. In many ways, disulfiram is emblematic of a very different culture of addiction medicine than the one that I was trained in, but it does have utility for the appropriate patient. Its nature as an aversive agent makes it more challenging to interpret in meta-analyses. The theoretical effect is that you know you're taking it and that there will be consequences if you drink. Historically, meta-analyses like the one on the slide have been unable to demonstrate a reliable effect for disulfiram, except when evaluating open label studies in particular. The patients need to know that they're taking it. Skinner et al. Performed a meta-analysis on the efficacy of disulfiram, which was published in 2014. And they did not demonstrate an effect in blinded studies. This is frank cherry picking of studies on my part, but this image is from a study done by Laxone et al. Published in 2008 on the comparative efficacy of initially daily naltrexone, acamprosate, and disulfiram up to 12 weeks. This graph depicts a Kaplan-Meier survival curve for abstinence from heavy drinking after randomization until the point at which patients entered the targeted phase for each of those medications. We talked about this trial a little bit earlier. Interestingly, what differentiates these patients from patients studied in other settings is that their medications were supervised throughout the period on this graph, in addition to the counseling that everyone received as a matter of course, and often does in these sorts of trials. There's an impressive separation in the curves for at least most of the assayed period, but the generalizability of this study to the average alcohol use disorder patient who takes their medications unwitnessed and is not in a controlled setting is limited. That said, the last year's network meta-analysis did demonstrate an impressive effect for disulfiram on both abstinence and heavy drinking. The authors attribute this change to a stratification of outcomes by abstinence and heavy drinking as opposed to pooling outcomes, and on the inclusion of a number of unblinded trials, recognizing the aversive nature of disulfiram is contingent on unblinding to some degree. There are heady statistics questions to be asked and answered about the transitivity of comparisons between disulfiram and other therapies in a network meta-analysis. But exploring that fully would take longer than the time that we have. Suffice to say, there are likely factors that differentiate patients enrolling in a disulfiram trial from patients enrolling in an acamprosate trial or a naltrexone trial, and that comparisons of their relative effects against placebo might not be completely valid. Topiramate is an odd drug used mostly as an anticonvulsant and as migraine therapy, but also for alcohol use disorder and a variety of mental health conditions. Trials have historically demonstrated fairly impressive effect sizes, but enthusiasm for its use has been tempered by a small body of evidence and concern with side effects, the most common of which can include paresthesias, dysgeusia, anorexia, and difficulty with concentration. Anecdotally, these side effects can be mitigated by increasing doses slowly over a period of weeks in many patients. Up until recently, the best synthesis level evidence for the use of topiramate came from this meta-analysis by Blockett et al. Published in 2014, which was inclusive of 7 trials with relatively impressive effect sizes. Topiramate doses varied, but were between 100 and 300 milligrams daily, and often up-titrated to doses higher than 100 milligrams. Major caveats for this meta-analysis include that there was on average a 12% dropout rate among the treatment groups as compared with 4% in the placebo group, potentially inflating the effect size, and that obviously this is a relatively small number of trials. Effect sizes in the subsequent network meta-analysis were more modest, with a rate ratio of 1.41 and a 95% confidence interval between 1.07 and 1.87 for abstinence. The effect was not significantly larger than would be expected for naltrexone or acamprosate, and there were more adverse events leading to therapy discontinuation in the dipyramide group than in the placebo group, especially relative to the better established therapies. All told, there's a place for dipyramide. It's one of the first-line agents recommended in the VA alcohol use disorder guidelines, even over acamprosate actually, and it's being explored for benefit in cocaine use disorder, but side effects continue to be the major barrier to its uptake. Baclofen is an antispastic GABA-B agonist used off-label in the treatment of GHB withdrawal here for the theoretical benefit of providing that GABA-B agonism that GHB provides and benzodiazepines don't. It has a much more recent Cochrane review than the other therapies, with a study by Minozzi et al. Published in 2018. Prior to the publication of this trial, the jury was very much out, with early trials showing striking reductions in drinking and subsequent trials demonstrating little, if any, effect. In the Cochrane review, they assessed 12 randomized controlled trials, notably inclusive of only 1,128 patients, given how many studies were included. And they evaluated the patients for return to any drinking, days of drinking, percentage of heavy drinking days, and safety and efficacy measures like adverse events, dropout rate, etc. There was no demonstrated effect for baclofen on any of the primary outcomes. And it's actually worrying evidence that baclofen was associated with an increase in the number of drinks per drinking day. Side effects such as vertigo, sedation, paresthesia, and rigidity were fairly common. The novel NMA had strikingly different results, with more reassuring findings in the safety markers and comparatively large treatment effects. Baclofen had a risk ratio of 1.8 and a comparatively small confidence interval for abstinence, and a likewise impressive and significant effect for reduction in heavy drinking. The authors attribute this difference to the inclusion of more trials, more than twice the trials at 16 versus 5, and differences in heavy drinking, where the Cochrane review looked at a change in heavy drinking, and the study looked at the absolute value of heavy drinking days. I'm not yet seeing this in practice, but I expect this to become part of the conversation in the coming years as guidelines are revised. And I do also hear that it has utility in the management of alcohol use disorder in patients with clinically significant liver disease and is used commonly in Europe. Theoretically, the combination of multiple drugs, as is common in psychiatry, might be of benefit for some patients for additive opportunities. Unfortunately, in most circumstances, this hasn't been borne out well in the evidence. The last systematic review looking specifically at combination pharmacotherapy was published in 2018, summarizing 16 publications, mostly combinations of naltrexone and another therapy, and failed to demonstrate any additive benefit for combination therapy over single agents. The lowest hanging fruit, combining the two first-line pharmacotherapies, has been evaluated most prominently in the COMBINE trial, which was a very large trial by addiction medicine standards, including 1,400 patients in 9 separate arms, including combinations of naltrexone, acamprosate, placebo, and counseling or no counseling, and following patients for up to a year. It did not demonstrate an additive effect to multiple pharmacotherapies over a single pharmacotherapy, but they also used non-standard doses of naltrexone and acamprosate. They're giving 100 milligrams of naltrexone and 3 grams of acamprosate, and they failed to demonstrate a significant effect for acamprosate at all in this study, actually. A very similar but much older, much shorter, much smaller trial published in 2003 by Kiefer et al. Randomized patients to naltrexone, acamprosate, naltrexone plus acamprosate, or placebo for 12 weeks, and they found combination therapy more effective than acamprosate, but not significantly more effective than naltrexone monotherapy. When I say combination therapy here, I say naltrexone plus acamprosate. In light of these trials, naltrexone and acamprosate are not commonly co-prescribed. The combination of naltrexone and gabapentin is the most common combination pharmacotherapy in my experience. The combination of therapies has not been borne out in synthesis level studies, but it's informed by a paper published by Anton et al. In 2011, in which 150 patients were randomized to naltrexone alone, naltrexone with gabapentin, or double placebo for 16 weeks. There was significant improvement in time to relapse to heavy drinking, number of heavy drinking days, and drinks per drinking day in the combination therapy group. Because of the design of the trial, these patients had their gabapentin stopped at 6 weeks, and those intergroup differences disappeared. It's worth recognizing that given how common this practice is, combining gabapentin with naltrexone, it's supported by a very small body of evidence for relapse prevention specifically, though the role for managing withdrawal symptoms with gabapentin is obviously still there. Ketamine in depression, and to a lesser extent in substance use disorders, is a hot topic at the moment. We've all likely seen ketamine clinics sprouting up from time to time, and it's natural to be excited about a new boom in the area of psychedelic medicine, which suffered relative stagnation for the better part of the 20th century, and has since become a topic of interest. The evidence for ketamine in alcohol use disorder is exciting, but modest and early. A systematic review was published earlier last year, highlighting the lead up to the paper most people are talking about at the moment, which was not included in the review. The review published by Garrell et al. Last year highlights 8 papers on the use of ketamine, although only 4 were in alcohol use disorder. The other 3 were on the use of ketamine as an adjunct for the management of complicated alcohol withdrawal, and mostly in the ICU. And among those 4, 2 were studies completed in Russia in the 1990s with a very different therapeutic approach, using ketamine in the attempt to create an aversive experience around the consumption of alcohol. They were also on almost exclusively very young Russian men. And this leaves 2 studies. One of them was this trial by Dakwar et al. In 2020, when they took 40 people randomized to either ketamine or midazolam in addition to motivational enhancement therapy once a week for 5 weeks and followed up for 6 months. There was more dropout in the control than in the intervention, which is common in these kinds of trials because it's very difficult to blind psychedelic trials. And they saw numerical improvements in abstinence over time, improvements in abstinence at 6 months, reduction in heavy drinking days, and time to relapse. But this is really small numbers. They had 6 people abstinent versus 3 people abstinent at 6 months, and group differences went away by the end of the study period. Das et al. Performed this slightly larger trial on 90 patients, 60% of which were male, and patients were randomized to 10 days of a combination of psychosocial therapy, ketamine once, or placebo once, and then followed up for 6 months. They saw reductions in the short-term volume of drinking, which returned to baseline by approximately 9 months after therapy administration. Really what people are talking about when they're talking about ketamine in alcohol use disorder is this trial published by Grabsky et al. Earlier this year and summarized as well by my colleague Dr. Polsky in her talk about psychedelics and dissociatives in the management of substance use disorders. The treatment was well tolerated and no serious adverse events were associated with the study drug. Although confidence intervals were wide, consistent with a proof of concept study, there were a significantly greater number of days abstinent from alcohol in the ketamine group compared with the placebo group at 6-month follow-up, with a mean difference of 10.1%. With the greatest reduction in the ketamine plus therapy group compared with the saline plus education group. There was no significant difference in relapse rate between the ketamine and placebo groups. So in summary, targeted naltrexone is a good option for some patients, especially after a period of daily naltrexone, but it's probably not as effective as daily naltrexone for most patients. Intramuscular naltrexone, the data are promising and improving, and hopefully it might be available again to our patients at some point in the future. Gabapentin has a limited evidence base, but it's a relatively common practice of giving gabapentin up to 600 milligrams 3 times a day, and it's often given because it has multiple indications, including the management of symptoms associated with early abstinence. Disulfiram is an effective option for the appropriate patient, such as one in a controlled setting with supervised administration or a patient that's highly motivated and has done well on it in the past. Topiramate is first line in the States and can be very effective, but requires counseling around the relevant side effects and uptitration. Baclofen is used in Europe and trials have been promising, but I haven't seen it as part of local practice, and side effects and its problematic withdrawal syndrome remain a concern. Combination pharmacotherapy is most commonly done with naltrexone and gabapentin, but there was a signal for greater effectiveness in combining naltrexone and acamprosate. And ketamine is very early in its evaluation, but there's real cause for excitement in ketamine-assisted psychotherapy. Of course, we need to make sure that our patients have access to the psychotherapy and not just the ketamine. Practically, up until quite recently, coverage for acamprosate and naltrexone was governed by the collaborative prescribing agreement, but as of April the 20th of this year, it is now a regular BC Pharmacare benefit. You no longer need to fill out your collaborative prescribing agreement. Anyone can prescribe this. It's eligible for Fair Pharmacare, Plan C, Plan G, and Plan W. I cannot speak about the management of alcohol use disorder without also making an application to local psychosocial resources. And of course, they vary heavily from location to location. And I can't understate how important it is to get to know the people that are working in your community, get to know the resources that are available in your community, and talk with your patients about what's worked well for them. I work in Victoria, and so here we have resources like the addictions outpatient treatment for counseling, both in groups as well as individually, our rapid access clinic, the Umbrella Society, which does fabulous work in both supporting patients directly as well as helping them navigate our system of substance use care. Mutual help programs, 12-step programs like Alcoholics Anonymous have a large body of evidence with some caveats for its application, but that can be effective for some patients. Newer programs like LifeRing, Smart Recovery, and Recovery Dharma offer alternative approaches to mutual help. And then for bed-based treatment facilities of publicly funded access and through Island Health, we have beds contracted at the Comox Valley Recovery Center, New Roads Therapeutic Recovery Community, Coastal Sage Healing House, Edgewood Treatment Center, Cedars at Cobble Hill, and just recently Homewood Ravensview. Of course, this is just a sample of some of the resources that are available in the community, and I encourage you to reach out to your colleagues about what is available specifically to you and to your patients. To return to my objectives, I hope we've sort of had an opportunity to think a little bit about how alcohol use disorder affects our both individual and collective health and how we can support our patients. To dive deep on the evidence that informs the standard recommendation for naltrexone and acamprosate. Be aware of some patient-specific factors that might, now we have a bit more nuance to make more specific recommendations, might work well for the person that's in front of you. Understand how to access additional information and clinical support, which is on the next slide, and feel comfortable prescribing at minimum naltrexone and acamprosate for alcohol use disorder. It's never been easier. I refer anyone that's interested, of course, to the 2019 guidelines, but this is the Canadian guidelines in alcohol use disorder among older adults from CCSMH are also excellent for the older patient. The 24/7 addiction medicine clinician support line is, of course, always available. And I'd like to personally acknowledge my mentor, Dr. Jankowski, Dr. Bach for his supervision, and this was originally developed based on a presentation that he gave here in Victoria last year. Dr. Polsky for her guidance on the use of ketamine in alcohol use disorder, and Dr. Dennis, another one of my co-fellows, for some guidance on how to interpret network meta-analyses. And these are my references.
Great. Thank you very much, David. Maybe just one of you over there. Great presentation. Great presentation, David. Really appreciated that. Lots of references, which means you must have done a good job. No, just joking. That was I really enjoyed how you sort of really systematically went through each medication, and particularly some of the less known medications. Anyone have any questions out there? Lots of things that were brought up. There's one question in the chat saying, can you speak to emerging benefits of Ozempic for alcohol use disorder?
Yeah, that's interesting. There was a trial, I think there was one that was published before I put these slides together originally, which was negative, which was from last year. I think there's another one that just came out about 2 months ago. I have not read that most recent one, but yeah, I mean, theoretically it makes sense. I'd be interested to learn more. Not something I have any expertise on myself.
Anyone else? Anyone? If there's anyone else who wants to comment on that, please feel free. Another question coming in: for someone who is presenting with acutely elevated transaminases, presumably from alcohol use, and you're worried about loss to follow up on discharge, when would you initiate naltrexone? How would you monitor? How much concern would you have?
Yeah, I mean, it's a good question. When the historically, if you go back for a long time ago, the recommendation used to be to check liver enzymes before you started naltrexone. Realistically, its safety profile is such that that was just an unnecessary barrier to put patients through, and so now the recommendation is just to do the follow-up enzymes. I think that concerns about the safety of naltrexone in liver disease are almost certainly overstated, and that this is a very safe medication which might actually prevent progression of the liver disease, and so I try to get it into people. And the actual likelihood that they're going to develop difficulty with their liver because of their naltrexone is so low. Practically, I just wait until the liver enzymes are downtrending, such that if they start to go back up again, I'm going to know whether or not it's something that I've done, but recognizing that alcoholic hepatitis or alcohol-associated hepatitis has this kind of waxing and waning course in some patients, it's not always clear. The ideal thing would be that they have good follow-up, but my practical recommendation is to wait until their synthetic markers look reassuring and their liver enzymes are downtrending reliably.
Great, thank you. We have a few more questions, so this is great. How much of a concern is gabapentin misuse or abuse?
You know, I don't really feel like I have the expertise to be able to answer that question myself. I don't see it very often. I do occasionally meet patients who are using gabapentin that may have been prescribed to someone else. I commonly meet patients who use more gabapentin than they're prescribed. Oftentimes they describe to me that they're mitigating symptoms from a particular withdrawal syndrome, but I'm not aware of any really strong epidemiologic data that would tell me about how common that is or really about the harm that's associated with it. I can only speak to my own personal anecdotal experiences.
Great. One question that I had actually is just some of the data that I found most interesting that you presented was the data on gabapentin, and particularly it's seeming to be much more effective for alcohol use disorder in people who have high reported withdrawal symptoms. And to me, that really seems so clinically relevant, right? When we're deciding when to throw in naltrexone as well, in addition to, throw in gabapentin in addition to naltrexone. So I'm just wondering if you could say a few more words to that slide that was discussing how did they determine what, what is high withdrawal symptoms? How can you give us a little bit of guidance on when we should really be trying to apply this evidence?
Yeah, so they did something a little bit non-standard in that they gave patients essentially a modified CWA score, and then they asked them to score themselves on the withdrawal, similar to like a subjective opioid withdrawal scale, and asked them to score themselves on what their level of withdrawal symptoms were. On the plus side, I guess that's more patient-centered and it's easier to administer, but I think it does also mean that we potentially have this other factor of withdrawal catastrophization that sometimes we see in our patients. My broad takeaway from that, given the way that they separated patients by how distressed they were and how significant they thought their withdrawal symptoms were, is that the patient that is really concerned about their withdrawal symptoms is also an appropriate patient for this strategy, as well as the patient that has obvious alcohol withdrawal symptoms. You know, like when you look back at the earlier gabapentin trials for the management of alcohol use disorder, because they don't stratify patients by this, the question is really like how much of the benefit of this prescribing pattern is coming from these patients who have high self-reported symptoms of alcohol withdrawal. And we don't really, I don't have a magic ball to be able to look back and sell on some of those earlier trials. But I think it's an interesting question. It's something that I'm trying to be more cognizant about when I prescribe it to patients.
So do you recall like specific symptoms that were most reported with self-reported withdrawal? Like, if we hear a patient say A, B, or C, is that something that we should be considering for gabapentin right away?
It was just the traditional CWA factors like nausea, tremor, anxiety, which is going to be even more subjective than it would be in hospital. They didn't have any factors on their subjective CWA that aren't present on the objective CWA we would typically use in hospital.
Gotcha. Okay, thanks. There's a question just about network meta-analysis as a method. Are there advantages compared to other systematic review methods? Maybe you can say a couple more words on that.
Yeah, so network meta-analysis is a technique that comes originally mostly from psychiatry trials. Sorry, do you mind muting over there? It comes originally mostly from to use networks with common comparisons to make indirect comparisons. That is to say, if there was a trial that compared paroxetine versus lorazepam for anxiety, but the trial didn't include each of those didn't include a comparison against placebo to use the magnitude of the effect in comparing those two agents to try to make comparisons that weren't done in the actual trials by accumulating enough data. The advantage of this is that it lets us try to make direct comparisons between medications that might not have been directly compared, or to look for the effect of a medication against placebo when it may not necessarily have been compared against placebo. But it requires on this assumption of transitivity, which is to say that patients who are randomized within one trial could also have been randomized into the other trial, which in substance use trials and in alcohol use disorder trials, especially ones containing aversive agents like disulfiram, is oftentimes just not the case. So it empowers us to be able to answer questions we couldn't answer any other way, but it comes along with some big caveats about how we should interpret these numbers.
Great, thank you. There's a comment about in remote northern settings, having seen gabapentin used recreationally, smoked or injected. I've also definitely seen patients insufflating gabapentin or using very large doses recreationally. So, you know, in our opioid crisis days, I don't know if this is the thing that we're most concerned about, but something to consider. Another question, are these treatments targeted to a particular treatment setting, for example, inpatient hospital, prior to surgery, inpatient substance treatment, outpatient? I'm wondering if they could be prescribed by a GP in a family clinic scenario, or whether greater structure expertise is required.
The vast majority of these trials were completed on outpatients after a 3-day period of abstinence. And so I think all of these medications nearly are appropriate for prescribing by a GP in a family clinic scenario. You know, with the exception potentially of therapies like ketamine, which need to come along with psychosocial structure and all of that organization that just doesn't exist within a publicly funded healthcare system yet. And then medications with particularly dangerous intoxication and withdrawal syndromes like baclofen. But certainly for naltrexone and acamprosate, they should ideally be prescribed in collaboration with a longitudinal care provider like a family physician, nurse practitioner.
Any other questions from the audience? A number of really good questions, so thank you for that. Great. Any last words, David, before we sign off? I know this is you know, the topic of alcohol use disorder gets a little bit pushed off the radar with our opioid toxicity crisis, but I think on a population level, alcohol use is still right at the very top of the harms caused by substance use in our society. So thank you for updating us on the evidence. Last thoughts before we sign off from anyone else? No?
I'm really grateful for everyone being here and for everyone's time. Have a fabulous afternoon.
Great, thanks everybody.